Dr. Romero, we are ready for you to begin the public comment session whenever you are.
Very good. All right. So we'll start our public comment session. At the outset, I'd like to welcome and thank our public comment speakers for addressing the committee today. Your comments and thoughts are extremely important to us, and I want to thank you for taking the time to do so. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined by a lottery. This comment is for the speakers. We have a limited public comment period, and in order to make it through all of the speakers, it's very, very important that each speaker limits his or her remarks to 3 minutes. There will be a display on your screens of the time, a circle that will go from green to red to indicate your time. As you proceed towards the end of your time, I will state, thank you for your comment. Your time is expired. If you exceed your time limit by 15 seconds, I will state, as a courtesy to other speakers, we ask that you conclude your comment. And if you prolong your talk for more than 30 seconds, then I will state that your comment time has ended. And thank you, and cut your microphone. So we'll begin with our first speaker, Ms. Hargrave. And please state your full name and your affiliation. Ms. Hargrave.
Thank you. My name is Allie Hargrave. I'm a working pediatric registered nurse in the state of Minnesota and a combat veteran of the United States Air Force. I am no stranger to witnessing vaccine injury. I came to this meeting to bring questions that, in my opinion, deserve to be answered before it can be deemed appropriate to distribute the fast-tracked COVID vaccine to frontline healthcare workers. Why are roughly 36% of nurses planning to refuse this vaccine and 31% of nurses unsure if they will take it? How do we know that there will be no long-term health consequences from receiving the COVID vaccine? Long-term injuries and ailments are a possibility from any pharmaceutical product. Therefore, it's questionable how the label of safe can be given to the COVID vaccine when long-term studies and monitoring have not been done. Is it possible that we will be sacrificing or risking widespread injury among our essential population of healthcare workers for this pandemic and potential future pandemics? What about paradoxical immune enhancement? You must remember the phenomenon that created lethal inflammation during the 2012 animal studies of previous coronavirus vaccine trials. When all the vaccinated ferrets were exposed to the natural infection, then died from the overly robust immune response. How can we possibly know that this will not occur again when animal trials were forfeited for the sake of an accelerated timeline? Again, is it possible we are risking our essential healthcare workers by not having these questions answered? And what about healthcare workers who have already recovered from the natural COVID infection? How will this vaccine act with the existing antibodies that they have? Is it safe to give this mRNA vaccine to people who have already recovered from the natural infection? Was this considered during the fast-track trials, especially considering how widespread the natural infection is amongst our healthcare workers? Finally, as a nurse, I'm legally bound to give informed consent prior to giving any medication or intervention. How will it be possible for me as a recipient to receive informed consent when the CDC website states that ingredients of the COVID vaccine may be withheld due to proprietary concerns and the phase 3 of the trials is still in progress? How can I receive informed consent without all the information available? With these questions, does it make sense for our frontline healthcare workers to receive this inadequately tested, liability-free vaccine when the nation is literally depending on them to guide us through this pandemic? How can you call yourself an advisory council when you don't have all of the adequate information to advise with? Thank you.
Thank you for your comments. Next speaker is Mrs. Ricardo. Please come forward.
My name is Ricardo, the República Oriental del Uruguay. I'm present the program last year and GIS presents a new program. They are intelligent artificials. The name is True Colors. Es una nueva óptica de ideas para put the end the coronavirus. The human body is un great universe and True Colors and searching new possibilities the put the end the coronavirus and other disease. I had the nuevo tools more efficient and vaccines in identifica bacteria and more data and more possibilities for efficient, the harmful, the vacunas and the humans. I connection the Embajada of the United States and Uruguay and since 6 years old. Only question no problem. Communication. Excuse me, my English is very little. I present the United States new option in intelligence artificial put in the coronavirus and more bacteria. Así que thank you very much. In the United States, you order, sir.
Gracias por su comentario. Thank you very much. We will move forward. Next speaker is Dr. Foreman. Dr. Foreman.
Dr. Romero, I don't see him on the call right now.
Thank you very much, Stephanie. Let's move forward and then come back to see if Dr. Foreman comes on. Mrs. Anagnasto, and forgive me if I mispronounce your name.
That's no problem. Can you hear me?
We can. Please go forward.
My name is Sia Anagnastu, and I've worked for nearly a decade heading up corporate development at a company called Immunomic Therapeutics. So we work on nucleic acid vaccines, quite similar to the technologies that underlie the COVID vaccines being discussed today, but we're focused on things like allergy and cancer. I'm also a co-founder and board member of Why We Vaccinate. This is a nonprofit that is dedicated to supporting vaccine education, awareness, and countering vaccine misinformation. So I want to thank you all for having this meeting today and for your individual and collective hard work and dedication to support the use of vaccines in the U.S. I want to also note that amongst all the complications of this pandemic, the committee has been working to hold these meetings and be transparent and inclusive in your deliberations, and for the overall process for how you make these recommendations. I support that you continue being transparent and inclusive. I think it'll continue to, or at least try to instill confidence in the process and in COVID vaccines in general, which we know is so important. Also, as a mother of young children, I see one of the challenges to public confidence in vaccines, and I think we're seeing some of that today, or we might in a couple minutes, is the influence of people and groups that continue to spread misinformation and disinformation. You know, we haven't always taken it very seriously, but I think we continue to see the deleterious effects before just on general vaccine uptake that protect us all, but now with COVID, misinformation is going to cast new types of doubt, and you know we've been seeing it about the safety and effectiveness, and this is possibly going to be harmful to all Americans, and even the ones that we've been talking about today who are most vulnerable to COVID-19. So I think, you know, just in general, the motion put forward today obviously has been done with extensive deliberation and consultation. And it's a great first step to protecting Americans from COVID and for the safe and adequate operations of healthcare providers and services. So I strongly support voting for the motion. But also I want to encourage CDC to continue to conduct education activities and outreach, and to be a trusted public source of information, because I think your credibility goes a long way to promote confidence in use of COVID vaccines. And I think we all need to try to directly address some of the concerns that Americans have about these vaccines, so that we can do our best to ensure widespread uptake, so we can all get back to normal life. So thank you all for the hard work that you do.
Thank you for your comments. Dr. Schmidt, please.
Thank you very much. My name is Harold Schmidt. I'm an assistant professor in the Department of Medical Ethics and Health Policy at the University of Pennsylvania. I'd like to start by congratulating the committee members and especially also the staff for their work. The complexity of data integration and the pressure, political and otherwise, is just intense, and I frankly have no idea how you do it, but evidently you do. All the best as the initial finish line comes into sight. I'd like to make 3 brief points that focus on promoting equity, both within priority phase 1 and beyond the consideration given to the priority groups. And I'd like to note that these comments build on collaborations with a number of colleagues, but in particular the outstanding economists Haifun Sörmes, Gru Umber, and Parag Pathak. So the first point is that allocating vaccines to states according to population does not help reduce inequity, which I take to be a central goal of the framework. For example, in New Hampshire, a little over 1 in 10 people is among the most disadvantaged nationwide, but in New Mexico, more than 3 in 10 using the SVI standard that the committee also draws on. And there are similar variations in the populations of healthcare workers, of course. So if we send vaccines to states based on the population, disadvantaged groups in states with above average shares face more fierce rationing. But that's not fair. It would hence be helpful to use the ACIP standing to urge more fair allocation to jurisdictions that takes into consideration their shares of disadvantage. Second, and related, the committee can still recommend that jurisdictions set aside extra vaccine amounts for disadvantaged populations. The NASEM report, which sought to assist ACIP specifically with addressing equity, recommended setting aside a 10% reserve at the federal level. While there's much other similarity between NASEM's overall approach and ACIP's, this proposal seems not to have carried over. This is regrettable, as we've shown in a study that a 10% federal reserve is the most beneficial for disadvantaged groups, including healthcare workers. But we've also shown that a 10% reserve at the state level can still meaningfully help disadvantaged populations. Pragmatically, and given where we are, it would hence be helpful if ACIP took up the NASEM's work and recommended that states and other jurisdictions strongly consider a 10% reserve based on SVI or related measure to further promote equitable allocation within each population group. In a separate study that we'll launch tonight, we compared all 64 jurisdictions' initial allocation plans and can report that the state of Tennessee already plans to do this, set aside a 10% reserve. So other jurisdictions can likely learn from this approach, as well as from 17 other states that plan to use the SVI to promote equity for worse-off populations in different ways. And lastly, technology can, of course, also enable equity. At an early meeting, ACIP suggested that the SVI could be integrated in the Tiberius software. And from the tenor of the discussion then, I assumed that this would be to enable jurisdiction planners using Tiberius to prioritize disadvantaged groups using SVI, but this seems unclear. Our analysis of the plans also show that 23 states currently plan on using Tiberius, including 15 that don't otherwise plan to use SVI for equity promoting purposes. So the index may do more work here, and it would be helpful to have clarity on this point. So in summary, aside from considering equity in the sequence of priority populations, ACIP can still promote equity further by recommending allocations to jurisdictions not by population, but by their share of disadvantage within healthcare workers or otherwise, recommending 10% reserves for disadvantaged communities at the state level, and building in SVI weights into Tiberius platforms as
Thank you for your comment.
Thank
Time
you.
has expired. Thank you. Next speaker is Mr. Kubbitz.
Yes, I am Kermit Kubitz. I was a polio pioneer in the 1954 vaccine trials, which ultimately reduced polio cases from 55,000 to 5,000 in the next 2 years. The recommended vaccine allocation priorities are well thought out based on goals of maximizing benefits, protecting public health and the healthcare system, and providing equity. You will vote on providing vaccination priority to healthcare workers in phase 1A. You may want to clarify that firefighters who act in many cases as healthcare workers and roll out to provide EMT services are included as healthcare workers for phase 1A purposes. My second recommendation, similar to the last speaker, is that geographic and state allocation of vaccines must recognize population densities and the availability of ultra-cold storage and allocate less stringently stored vaccines to states and rural areas within states without deep cold storage if two different kinds of vaccines are available. Third, follow-up of vaccines should include not just safety, but studies of effectiveness based on different populations and groups, potential flaws in logistical distribution and handling of vaccines, delays in dosing, or other issues which can affect effectiveness. So there should be follow-up. Fourth, and I emphasize this, remember and plan to avoid laxity in non-pharmaceutical interventions such as masking and distancing by vaccinated persons interacting with unvaccinated populations. The vaccine may limit symptoms and illness, but may still allow infection and transmission. So you must have a plan to assure masking and distancing are still implemented until vaccines are widely available and used. And finally, as essential workers, I do recommend giving some priority to people who have participated in vaccine trials and received a placebo. Once an approved vaccine is available, those who received a placebo should get the vaccine even at the cost of less follow-up of a placebo group, because the trial participants, are truly essential workers. And just to clarify on EUA fact sheets for everyone involved, it is my understanding that one thing about an EUA vaccine is that people do have the right to choose not to use a vaccine approved through EUA. That is, EUA vaccines are voluntary. Thank you.
Thank you for your comments. Next speaker is Dorrit Reese, please.
My name is Dorit Rice. I am a professor of law at the University of California, Hastings College of the Law, and a member of the Vaccine Working Group on Ethics and Policy. I have 4 points to make. ACIP plays a critical role making recommendations that the Public Health Department and healthcare provider recognize as authoritative and fact-based. ACIP recommendations are always critical, but even more so in a public health emergency, particularly the kind of fast-moving emergency we're in now. While the public may not be aware of all that ACIP does, the public benefits from the deliberations of this committee and relies on its expertise. It is critical that ACIP continue to play this critical role for COVID-19 vaccines. Second, in previous commenting sessions, members of Correction Officer Association asked you to consider including their members in the highest tier. I support the recommendation, and it's clearly too late for this part, but I want to reinforce the message that while level of outbreaks in jails and prisons were not as bad as in long-term care facilities, they were high. And in both cases, we have a captive population, and many in prisons and jails are at high risk. Correction officers are the bridge to the community and may bring in COVID-19, but they're not healthcare workers and not covered in the first tier, most of them. Maybe they should be, because prisoners are exposed to COVID-19 through no choice of them. Many are in prison for things that don't deserve COVID-19 as a penalty, and some are in jail innocent. Third, and this is a bit of a response to the previous comment, although the FDA and CDC have previously categorically stated that EUAs do not allow mandates, I think that's a misreading of the statutory language. The statutory language allows the Secretary discretion on whether mandates are allowed, and a categorical prohibition on mandates by private business may be vulnerable to legal challenges as a misuse of discretion. I think the advisory committees need to consider to what extent an EUA should allow mandates. And that's more to FDA than to you, but I want you to be aware of this. Finally, to echo comments I made in the past, I think ACIP should make public participation in its deliberations written only, at least for the near future. As you all know, all commenting before you have been used by anti-vaccine activists to create propaganda movies for their own community, under the heading of, these are our comments to CDC. Transparency is important. Participation is important. But contributing to anti-vaccine propaganda is not a legitimate role for ACIP. You are promoting transparency by having this public discussion, and you should keep doing that. You're providing an opportunity to public participation by having easily accessible written comments. You do not need to also provide a platform for making anti-vaccine videos. Thank you very much.
Thank you very much for your comments. Let me go back to Dr. Foreman and see if he is available. Stephanie, do you see him in the waiting room by chance?
No, Dr. Romero, I didn't hear back from him either. He must have not been able to wait.
Okay, thank you very much. So then this closes our public comment section. We thank all of the public speakers for taking the time to address us. I'm going to ask the voting members to please unmask themselves or open their videos as we move to the next stage.
And Dr. Romero, I just want to let the viewership know that the public docket, while it is open for acceptance of comments at this time, it will not be open for review by ACIP members or the public until tomorrow, but it will be open at the link tomorrow.
Thank you. Very good. Then, Dr. Dooling, can you put your slide up, please, with the motion in a second? All right.
Sorry, we have reworded in accordance with feedback received in the last round, and we're just going to put that reworded that just clarifies the intent.
Okay. I believe because there has been a change in the wording, we're going to need a motion and then a second once again.
Dr. Romero, because the wording is incredibly minor and just for clarification, there's no change in the intent of the recommendation. We can go with the original motion.
Very good. It's so deemed.
Next slide, please.
Dr. Dooling, would you please read it again to the committee for vote?
When a COVID-19 vaccine is authorized by FDA and recommended by ACIP, vaccination in the initial phase of the COVID-19 vaccination program, Phase 1A, should be offered to both healthcare personnel and residents of long-term care facilities.
Thank you. So, are there any other comments from the voting members? Okay, I see none. So I will call the roll and ask for a vote. I will then tally the vote and announce the results, and then we will open for comment. So as chair, I will vote last. Let me begin with Dr. Atmar. Dr. Atmar.
Atmar, yes.
Thank you. Dr. Alt.
Alt, yes.
Thank you. Dr. Bata.
Bata, yes.
Thank you. Dr. Bell.
Bell, yes.
Dr. Bernstein.
Bernstein, yes.
Dr. Fry.
Fry, yes.
Dr. Hunter.
Hunter, yes.
Dr. Lee.
Lee, yes.
Ms. McNally.
McNally, yes.
Dr. Paling.
Paling, yes.
Dr. Sanchez.
Sanchez, yes.
Dr. Szilagyi.
Szilagyi, yes.
Dr. Talbot.
Talbot, no.
Did I miss anybody in that roll call? Romero, yes. So my tally, which I will ask Dr. Cohn to confirm, is 13 in the affirmative and 1 no. Is that correct, Dr. Cohen?
Yes, Dr. Romero, that is correct.
Therefore, the motion passes, and the interim recommendation stands as when a COVID-19 vaccine is authorized by FDA and recommended by ACIP, vaccination in the initial phase of the COVID-19 vaccination program, phase 1A, should be offered to both healthcare personnel and residents of long-term care facilities. So now I will ask for any of the voting members that wish to offer comment, and I will begin, if I may, as chair's prerogative. We have spent 8 months discussing and evaluating the data. I think that whatever we have asked for has been presented to us and has been clearly discussed both in the work group and in a public setting. Our discussions have been transparent and our motives have been clear. As is stated previously, we are using the principles of maximizing benefits and minimizing harms, promoting justice, mitigating health inequities. Those of us that are in the area of public health at this time see the growing number of cases that is coming before us. We see the growing number of healthcare providers that have become infected, and some of which unfortunately have passed away. We see that the individuals living in long-term congregate facilities, long-term care facilities, are at exceptional risk for mortality and morbidity due to this virus and disease. I believe that my vote reflects maximum benefit, minimum harm, promoting justice, and mitigating the health inequalities that exist with regard to distribution of this vaccine. It is because of that that I voted in favor of this motion. We'll take other comments if anyone wishes.
Dr. Romero, I'd like to make a statement. Oh, go ahead, Veronica. Please go.
On the policy question before us today, I voted yes after careful consideration of the science, the implementation considerations, and the ethical principles. It became clear to me that this should be the vaccine allocation priority for phase 1A. As a consumer representative of the ACIP, I place significant value on the routine safety surveillance systems and new systems in place that the ACIP has asked the CDC to be sure to employ and to be sure to meticulously assess the data gathered. I want to note that I am also confident that the consent assent issue for long-term care facility residents required to receive the vaccine will be given the attention it deserves, as we heard today, in reassurance by Drs. Oliver and Messonnier. I would like to close my comment by thanking the COVID-19 team at the CDC for your incredible efforts thus far. We owe you a debt of gratitude that I don't think that we will ever be able to adequately convey, and we look forward to continuing to work with you during this challenging time. Thank you.
Thank you very much. Dr. Paling, I see your hand is up.
Yes, thank you. I wanted to, I voted yes, and I also was focused on maximizing benefits, minimizing harm, promoting justice, and mitigating inequities. Healthcare personnel have high exposure to COVID-19 and need to be available to meet the increasing health needs of all Americans. It's important to emphasize and include the full diversity encompassed within healthcare professionals, as well as the opportunity to mitigate inequities. I encourage all who will receive COVID-19 vaccines to volunteer to participate in the Be Safe established to efficiently monitor safety of all COVID-19 vaccines. Post-approval monitoring of vaccine is standard for many decades, and individuals and providers have the availability to report and are strongly encouraged to report to VAERS. VAERS is co-managed by the CDC and FDA for all vaccines. As to the long-term care facility residents, they have high risk, as is demonstrated by the fact that less than 1% of the population, they represent less than 1% of the U.S. population, yet they represent a disproportionate rate of disease and death. 6% of all COVID cases and 40% of deaths. The efficiencies gained by administering vaccine to residents and staff with pharmacy partners really is important to acknowledge. The consent and assent process for the long-term care facility is appropriate and needed and nicely complements the enhanced safety surveillance systems established. While it would be nice to have additional data on this population, that is not feasible during this pandemic, and with the disproportionate share of deaths belonging to persons who live in long-term care facilities, I believe it's important that they be included as well. Thank you.
Thank you for your comments, Dr. Palin. Dr. Szilagyi?
Yes, thank you. First, I wanted to really thank the COVID-19 work group and the enormous CDC team and liaisons for the incredibly careful, thoughtful, collaborative work. This has been just an amazing experience, and I'm honored to be participating in this process. To me, this has been a Solomon's choice, since we all feel that all U.S. residents should eventually have access to safe and effective vaccines, but we will all have access very soon. I strongly agree with the recommendation to allocate both healthcare providers and residents of long-term care facilities to phase 1A, with the assumption that FDA and ACIP would only recommend a vaccine if the best available evidence shows it's effective and safe. I do feel this prioritization represents strong consideration of the frameworks of science, implementation, and ethics, and helps to maintain our healthcare system and protect a very fragile population. And finally, I want to emphasize that post-recommendation guidance and support for implementation and safety monitoring is critical, and as we heard today, it's being planned extremely well by CDC. So I just want to end by something that I sometimes talk about in talks. One of my favorite people, Mahatma Gandhi, said, "A nation's greatness is measured by how it treats its weakest members." And I feel prioritizing healthcare providers and prioritizing residents of long-term care facilities represents the right decision at this time. Thank you.
Thank you, Dr. Szilagyi. Dr. Bell.
Thank you. I wanted to simply reflect on the weight of the decision that we are making today and the process that we are embarking on, and to say that, we all would like to know more, but there comes a time when we go through a process, we evaluate carefully every bit of information that we have access to, and then we need to act. And I find that the consistency with which all of my colleagues on the ACIP are essentially coming up with the same way of looking at the evidence that's available to us and coming up with the same conclusion, I think is testament to not only the fidelity of the process, but also, I think, the soundness of the thinking and of the conclusion for this moment. And I think that is an important part of all of this, that we are acting now in the way that maximizes benefits and minimizes harms at this moment, and we will continue to go forward as we're able. So I in addition to thanking all of the CDC people and the work group, I also just wanted to reflect on and thank my colleagues on the ACIP for continuing to work through all of this with all of us and, come up with a very similar assessment of what is the best choice to make at this time to save the most lives and prevent as much disease as possible.
Thank you, Dr. Bell. Dr. Lee.
Thanks very much. I just wanted to make a couple of brief statements. So, I really see our job at ACIP is to take care of the public at a population level, and then our job as healthcare providers is to take care of individuals of the public at the individual level. And phase 1A, I think, enables us to hopefully preserve that healthcare capacity before it's too late. And I really wanted to thank all of our frontline workers for all of their service to date. It's been an exhausting 9 months, and all of us are in this together, but really appreciate how much our healthcare delivery systems and our public health colleagues have done. For the residents of the long-term care facilities, I just want to recognize and really appreciate my colleagues' comments about continued vigilance around safety surveillance for all populations, but in particular this population. I do want to recognize that this medically fragile population has a high risk of mortality without COVID. I hope that this creates an opportunity for us to prevent mortality in this population that's attributable to COVID. So hopefully this will have substantial health impact on that high-risk population. Finally, I just wanted to make a statement that we must address health equity as a core component at every stage of allocation. And, our job is clearly not done. We are just at the beginning part of this. So I wanted to take a moment to thank our colleagues at CDC, at all the states and jurisdictions for their leadership during this critical time. It's been really challenging, and I have really appreciated how so many people have stepped up, given all the challenges. And the implementation of this will belong to all of us, and we'll continue to need to work together in order to get through this pandemic. Thank you.
Thank you, Dr. Lee. Dr. Alt.
My comments were going to be very similar to everyone else's comments, so I don't want to duplicate too much. However, I have been participating in ACIP meetings for the last 15 years in various capacities, and I thought the discussion over these last few meetings has been excellent, along with the presentation, and certainly transparent and very well done for everybody that was involved.
Thank you, Dr. Alt. Dr. Talbot.
Odd woman out, I guess. I wanted to say a lot of things. One is I still struggle with this. This was not an easy vote. Two, I really hope this highlights that our skilled nursing facilities are a population that need lots of vaccines, not just COVID. And we really need to start finding ways of developing and testing these vaccines to prolong quality of life for our long-term care facility residents. I think that's key. I also want to say out loud that I have no reservations for healthcare workers taking this vaccine. We are going to see some amazing data about a respiratory vaccine like we've never seen before, and it's incredibly exciting. And I want the healthcare workers out there to know that I have no reservations about that whatsoever. So thank you for letting me serve, and I'm very glad it's a village and not one person.
Thank you, Dr. Talbot. Dr. Sanchez.
Okay, sorry. Sanchez, I really want to just take the opportunity to echo the previous comments and applaud the CDC COVID-19 team for their wonderful and astute guidance. I feel very strongly that we must vaccinate our healthcare workers, so that they can remain healthy and uninfected, so that they can provide care for the entire population. To me, that's completely clear. And I also feel very strongly that we need to protect the highly vulnerable elderly population and others who provide their care in long-term facilities. In many ways, I really feel that those are the ones who should come first, because they've given so much already to society. I recognize the continued need for optimal safety monitoring, but I really am convinced that this will be the case as we see this pandemic continue and cause significant harm to our society and to people. Thank you.
Thank you, Dr. Sanchez. Dr. Atmar.
Thank you, Dr. Romero. I want to add my thanks to the COVID-19 work group and the workers at the CDC for putting the data together over the last many months that we've had to consider leading up to this initial interim recommendation. I'd like to also remind everyone that this recommendation is only for vaccines that end up being recommended by the ACIP. So as individual vaccines receive emergency use authorization, we will have more data to consider, and that could lead to revision of our prioritization based on the content of the EUA and the data that support it. And while I shared many of the concerns that led Dr. Talbot to her vote about residents of long-term care facilities, ultimately I was persuaded by the tremendous burden in terms of mortality and hospitalization that the residents of these facilities bear, the remarkable efficacy that has initially been reported that ultimately we'll have a chance to review, being much greater than what we've seen with influenza vaccines. And so there is at least some hope that it will have some level of efficacy in this population. And the plans for monitoring of safety in this population and the extra mile that will be pursued to make sure that both the residents and their families are fully informed about the amount of evidence that's available before the residents receive the vaccine. That concludes my remarks.
Dr. Romero, do you want me to go to the next person?
I'm sorry, I was muted. I called Dr. Fry's name. Forgive me. Dr. Fry, please.
Thank
Give my
you.
oversight.
Thank you. I also would like to thank the COVID working group and all the CDC members who have participated heavily in this process, as well as their consultants, and also the the representatives of the professional organizations who also are able to interact with us at these meetings for all the outstanding work that they have done. Actually, Dr. Atmar said what I was going to say, is that what we are looking at here today is allocation of vaccine and not voting on any particular vaccine, and that we are trying to figure out the best way, and this is not an easy process, but to figure out the best way to allocate vaccine when it is available. There will be other votes for for recommendations for use of vaccines when the time is proper. So this is really just an allocation exercise. And so even that in and of itself has been extremely, I think, angst-provoking for many people. But I strongly agree that we are headed in the right direction here. Thank you so much.
Thank you very much for those comments. Ms. Bata.
Thank you, Dr. Romero. As we have been deliberating over this very first group of people who will get some limited doses of vaccine, I've received many pleas from many people all over our jurisdiction to consider them as a priority, and I'm encouraged by the fact that we have some vaccine products that are on the verge of becoming available. I appreciate the desire that so many people have to get protected, to move us beyond the terrible disease that we're seeing, and to encourage them that even though they may not get these first doses, it is important to protect them too. And I look forward, as others have mentioned, to moving into the approval process of the vaccine products that will become available once we've reviewed the data and acknowledge that this is an allocation recommendation and not a vaccine recommendation specifically. Thank you.
Thank you very much. Is there anyone else who wishes to make a comment from the voting members? Dr. Cohen, Dr. Massonier, do you wish to make a comment?
This is Dr. Cohen. I would just like to thank the ACIP committee, liaisons, ex officios, the ACIP COVID-19's work group and the safety subgroup, as well as our fearless CDC leads for those work groups and team for all of the work that went into this over really since March or April. I also want to let everybody know that we anticipate that the next ACIP meeting will occur sometime after the VRPAC meeting, and ACIP will be voting to recommend products after ACIP has reviewed the data from the phase 3 clinical trial, and after FDA has authorized, has issued an emergency use authorization for a product. So we will not be having a meeting in the interim, but we do anticipate having a meeting shortly after the December 10th VRPAC meeting, and more details will be made available soon. Thank you.
Thank you. Anybody else? Dr. Massonier? I don't know if she's still here.
No, I'm still here. I will just add thank you to the public. Yeah. Thank you to the public and for all the folks that are out there listening to what we consider really an incredibly important meeting, and to all the people out there that are anxiously waiting for this vaccine. We hope that this vote gets us all one step closer to the day when we can all feel safe again and when this pandemic is over. Finally, I'd like to thank you, Dr. Romero, for presiding over this meeting so well, and frankly, for all the work over the past year that you've given to the ACIP. We really do appreciate you. Thank you.
Thank you. So anyone else, last chance? All right, then I'll take Chair's prerogative to make this very short. Again, I think everybody has mentioned their thanks to our work group leads. I want to give my thanks in particular to Dr. Bell, our work group chair, all the members of the ACIP, all the support members of the CDC that have supported us throughout these months. It is an incredible honor and I'm humbled to lead you all. So thank you all very much. We will see each other, I think, in a few days on video again. Be safe. And with that, if I had my gavel, I would gavel us out. But imagine the sound of a gavel. We are over for the day. Thank you very much. Meeting ended.